Okay, we are live. Um, Good afternoon. I guess afternoon, evening, it's hard to tell when time changes if we're actually afternoon or evening, but want to welcome everyone who has joined us for this monthly installment of our New Mexico Kidney Foundation's Kidney Talks. We're looking today with Dr. Barrantes, our chairman and the board, and a doctor here at Renal Medical Associates, talking about diabetes, medication, and kidney disease. And so I wanted to note a couple of things. First off, for those of you who were expecting us last week, we apologize for the scheduling conflict and moving it to this week. Please keep looking for us on the first Wednesday of each month. We will continue to shoot for that as our regular time for doing our kidney talks. And the other thing I would like for you to watch should be a prompt at some point during the live presentation that will allow you to go to our webpage, the section that's called Help Us Make a Difference, which gives you various options to assist, whether it's volunteering, donating, taking actions to help us in the fight against kidney disease in New Mexico. So I wanted to make you aware of that so you could be looking for it as we go throughout this presentation. So with that, what I'm going to do is turn it over to Dr. Barrantes. As we did with last month, and what we intend to do during these presentations is to have a presentation given by an expert, in this case our chairman, Dr. Barrantes, as well as followed by a section of question and answers in the chat portion of it. So with that, let me go ahead and go to full screen. And Dr. Barrantes, I will give it over to you to do the presentation.
Very good. Thank you, team. I appreciate the time that all the attendees are coming today to talk to us, to meet virtually, and I have immense pleasure to share what I have learned over the past few years about diabetes and kidney disease. And it's an evolving field, and it's a very interesting what we have learned. Newer medications are coming in the pipeline that is helping us to treat diabetes, kidney disease in a different way. I'm going to share my screen now, and please tell me, Tim, any technical difficulties, okay?
Very good. There we go. Excellent.
Okay, very good. So I wanted to first to recap what we learned last month. So there's one basic statement: diabetes affects the kidney. That's period. That's well known. That's not a perhaps, maybe. Diabetes does affect the kidney. The longer patients have diabetes, either type 1 or type 2, the kidney will likely get affected. And as this picture shows, you have a kidney there on the left side, you have a kidney unit, which is the glomeruli, and that kidney, you see the red string there within the blue bubble. So the blood comes in the red string, and then the urine comes out. And in the diabetic kidney, you have the same thing, but you have this, this protein leaking, in the urine, and that's a problem. That is, you have an inflammation going on in this filtering unit that allows that the kidney start losing some protein in the urine. If you look at more at a microscopic level, and this is a graphic that kind of would explain more in the letter A, the first picture on the left side of the screen, is a normal kidney glomerulus, so which means it's a kidney that is healthy. So you have, this is inside the units of the kidney, We have 1 million of these units in each kidney. This is the
Wow.
inside. You're going to have these cells that's called podocytes. You have these mesangial cells, like a little purplish looking. You have these capillary loops that's where the little tubes of blood that comes and where the filtration happens. And then you have this light sort of brown. That's where the all the urine that we don't need comes collected. So I want you to compare this picture to the right side, which is a diabetic kidney glomerulus, so meaning the unit that is affected by diabetes. And what difference do you see? You see a difference of you see more of these mesangial cells. You look at these purplish cells. You have many of them. You have this thickening of the GBM, which is the glomerular base membrane. You have this green, like a snake looking surrounding the capillaries. The green structure that is a thickening of this area that will contribute to the protein in the urine. And then you have this. You look at the podocyte cells, which are these cells that have this kind of food processes around the capillary loops. You see that there's a food process effacement. So these little food structures are gone. Pretty much, we lose them, and that allows also the protein in the urine. So these changes are real. That happens as the patient has more hyperglycemia, uncontrolled high blood sugars, and occurs over the course of years. It doesn't come in one day, in 1 week, or in 2 weeks. This happens in the course of different years. So now, as we go, team, is everything's okay?
Yes. Yes,
Okay.
it's going well.
Okay, very good. Okay. So I wanted to move to the next slide. So this is another picture of what I just said here. You have at the left side, you have a normal unit. So you have the red string bringing the blood to this unit, the glomeruli, and then you have the proteins that are getting filtered out. You see the white, the yellow structure, kind of these little round things are the proteins. They're getting kind of filtered, and then some of them they get reabsorbed, and I would say the majority of them are getting reabsorbed, and then only a few dots comes out, at the end of these tubes. If you look at the collecting duct, which is the end of this piping system, you see only a few structures coming out there. If you go on the right side, you're going to see the diabetic kidney. And I want you to look at different structures here. You look at the red structure on the left side compared to the right side. You see how one of the strings are much bigger, and we call that vasodilated. It's kind of wider. And you see inside the red structure how thickened looks compared to the one in the left side. So that's the diabetic component. And then you see what has been filtered out in the yellow structures. You see circles are green, you have square shapes, you have green, you have blues. You have more stuff in here that has been filtered out of this system of pipes. And then more of this stuff is reabsorbed in this pipe system. You see this purplish kind of sort of area that is more collected there. And then you have some of whatever is filtered out, some of this comes out like a little square that comes out that is different compared to the normal kidney. So you have more stuff that is getting filtered through. So the distal part of this filtering area has to work harder to reabsorb what has been filtered through. But despite of that, we are still going to lose some of the proteins, some other stuff that we don't need to lose. Okay. So team, I make a little parenthesis here. I got a message from one of the members that they say they were trying to join the Facebook Live and nothing happens when click on the
Right.
link in the Google box.
We'll work on sending them a link directly to them.
Okay. Sounds good. Okay.
Thank you.
So so this is what's happening in the diabetic kidney. So you have increase of the thickening of the structures within the glomeruli, and then you have more stuff that gets filtered through the process, and then the structures after this filtering unit have to reabsorb more of what has been filtered out. It has to work harder. So what's happening in real life is this. You have in A picture is the normal filtering unit sort of looking. And then in the B picture, you see this thickening of this capillary. You see some of this dark pinkish material that is deposited in the unit. This is the beginning of the damage. And in the C picture, you see more of the damage occurring. In the glomeruli, you see more of this deposition of this pinkish material. And then in the D picture, you see much more pronounced. In the E, you have more a different type of structures that are developing. And then in the F, you see the glomeruli pretty much is dead. So the filtering units is pretty much gone. Mm-hmm. So the kidney is failing. So if you have this happening to every unit, over a number of years, the kidney gradually will just start failing little by little. So we know that diabetes damages the kidney. So can we treat it with medications? Can we do something about it? So if you came to see me, 3 or 4, I would say up to 2 years ago, I say, yes, we can treat. We have one group of medication, perhaps 2 groups of medication that we can use, and that's all we have. And then we have, obviously, diabetes management, hypertension management, weight management, make sure it doesn't take all the medication that can affect the kidneys. But now we have all the new things that are coming up that we using specifically to treat diabetes in the kidneys, and it has been so exciting in the last couple of years to learn this new research that has been published, and I will share with you this in the latest slides. So, what can we do? So again, this is the filtering unit. You see in the far left is normal filtering unit. With the one that we talk about with diabetes, you see this dilated blood vessel in one side. You see this leakage of the protein, which are the blue dots, and you see this constricted efferent arteriole, which is one of the blood vessels from this unit is dilated, and the other is kind of narrowed down. One of these blood vessels, if you concentrate in the center picture, you see the dilated one. There's more blood coming into the filtering units. That means with more pressure, and then you have the unit that takes out the clean blood, which is the constricted efferent, is kind of more narrowed down. So there is a lot of pressure happening in the unit. So we can use medications to lower the pressure in these units. And that's this group of medications are called ACE inhibitors or angiotensin receptor blockers. So the example of these medications are, for example, captopril, which is a very old medication, lisinopril, enalapril, fosinopril, valsartan, losartan, candesartan. Many of the medications ends in artan. So these are just examples of this medication that we use. So this medication, what they do is they decrease the pressure in one of these blood vessels and allow the pressure to reduce in the glomeruli, and therefore you lower the protein in the urine. That's the way this medication works. So they lower the pressure in the glomeruli. They are also blood pressure medication at the same time, but they have this particularly effect specifically in this efferent arteriole that dilated and then lowered the pressure. So this medication has been available for several decades and has been the cornerstone to treat diabetic nephropathy, or meaning diabetic kidney disease. In the last few years, we have a newer group of medication that you may have heard. This is called Jardiance, Invokana, or Farxiga. They are we call it SGL2 inhibitors. So remember the picture I showed you. If you concentrate in the left side, you see you go down on the diabetic nephron, and the left side, you see the red stuff, and then you have the system of tubules of the filtering unit. And we talk about all the stuff that gets filtered out, and we talk about all the stuff that has to be reabsorbed because of what has been filtered out. And this gets reabsorbed in the system through this marker called SGL2. So it's like a protein that we have there, like a little door that we have in the cells, in the tubules, there in the kidney, that kind of makes that reabsorption happen. So if we block those receptors, we call it receptors in medical terms, if we block these receptors with a medication, then we are going to decrease the reabsorption of this sodium, this glucose that gets reabsorbed, and therefore we're going to pee it out. So in other words, we're going to pee it out more blood sugar, we're going to pee out more sodium. And that's the effect. By doing that, you lower the pressure in the unit, in the red structure. We lower the amount of salt, we lower the amount of water in our body, so it lowers the blood pressure too, it lowers the risk of cardiovascular disease, and improves the GFR, and improves the protein in the urine in the long term. So these new SGL2 inhibitors are becoming a cornerstone of the management of diabetic nephropathy. So if you have diabetes and your diabetes, and you're taking the traditional agents such as captopril, lisinopril, enalapril, and your diabetes not well controlled, or you still have protein in the urine, you may want to discuss with your doctors whether you can take these medications, empagliflozin, canagliflozin, or dapagliflozin. These are the medical names, but you have also the trade names there next to it. So these are a newer medication. They sometimes take a little bit of work for insurance approvals to get this because they are expensive medications compared to the other ones, but they do work. They do improve the outcomes in the patients in the long term. Now, there's another group of medication that one of the reps of this is called finerenone, or the trade name is Kerendia. That's the name you find it in the pharmacy, Kerendia. So this medication, what they do is it blocks this. It's called you have a hormone called aldosterone. Aldosterone is a hormone that we have in our bodies, and this aldosterone has a different functions, And remember, I show you in here. I saw you go to maybe picture D, E, and F. You see all this blue. To happen, for this to happen, there are a lot of chemicals in our kidney that get activated and develop this we call fibrosis. And there are a lot of chemicals that make a cascade of processes that develop this scarring in the kidney, damage of the blood vessels in the kidney, damage of the urine in the kidney. And it seems to be that aldosterone is one of the hormones that sort of carry out part of this inflammation, this inflammation milieu that researchers have found that if you block the aldosterone with a drug, like for example, finerenone or Kerendia, you can lower the renal inflammation and fibrosis, and therefore you can decrease the diabetic disease. You can decrease the renal injury, you can decrease the narrowing the kidney, narrowing of this blood vessel, you can decrease all the inflammation. So this medication has recently also been approved by the FDA and is available to be used for diabetic kidney disease. So these are the three major groups that we have. We have the traditional agent, the ACE inhibitors, and like captopril, losartan, lisinopril. You have the new SGLT2 inhibitors, and you have the agents that lowers the inflammation within the kidney. So, like any medications, they have side effects. Even you take an aspirin, you have a Tylenol, you have side effects. So there are some well-known side effects of, for example, of the ACE and ARB group. They do increase the creatinine by 10 to 20% when we start the medication. They can increase potassium. Medications like captopril, lisinopril, and enalapril, which are called ACE inhibitors, they can cause dry cough. So if you have a dry cough and you are taking the medications, make sure you bring it up to your doctor, because if you change medication, that can get better. It can react with other medication like NSAIDs, ibuprofen, Motrin, and Aleve. So meaning that if you take this medication with NSAIDs, it can cause kidney problems. And it can react also with Bactrim or sulfur-related medication. So you have to be careful. If you're taking medication, you have to tell your primary care, or you have to, if you go to the urgent care, the ER, let them know, because they may give you another medication that can react with medication and cause more kidney problems. And also it can cause low blood pressure. What are the side effects of the SGLT2 inhibitors? There are some side effects. We talked before, they increase urine infection. You're basically blocking this receptor from reabsorbing what has been filtered out, in the unit. So you're going to pee more blood sugar. You're going to pee sugar. You're going to pee sodium. So people are going to have more urinary infection because there's a lot of more sugar in the urine. People can have more genital mycotic infection, which means fungal infections, like a yeast infections. More common to have that, especially in females. People can have dizziness and low blood pressure because they're peeing sodium. It's like a diuretic, essentially. So you're going to have more of the symptoms. And the finerenone, the side effects is hyperkalemia. Aldosterone is one of the hormones that modulates or regulates our potassium. So you're going to have high potassium levels. You can have low blood pressure. You can have low sodium levels. And if you have adrenal problems or certain medications that interact with the liver, you have to be careful with Kerendia. So your doctor has to look at what medication you're taking and see if it fits on your treatment plan, or if any changes need to be made before you start taking this Kerendia. So this is essentially what medications we have available. I wanted to end this talk by taking some home points here for you. Diabetes affects the kidney. Uncontrolled diabetes greatly affects the kidney. And remember always, the longer diabetes people have, the most likely patients can develop kidney disease. There are medications that can lower the kidney disease progression, such the older one, like lisinopril, enalapril, losartan, valsartan, candesartan. They all are very good. They are very effective. They are cheap. They do have they have some side effects, but they are very good. Newer agents, such as what we talk about, Jardiance, Invokana, or Farxiga, they are shown to benefit to reduce kidney disease progression. They also have shown improvement in blood pressure, improvement in cardiovascular, meaning cardiac issues. Issues that have to do with the cardiovascular system, and also decreased risk of people dying from these events. decrease risk of progression towards kidney failure, kidney disease, by blocking this receptor. Similarly, finerenone is becoming another agent that is being used increasingly. All these medications, they do have side effects, and you have to discuss this with your providers. Remember, by giving you this medication, you're only treating the diabetes in the kidney, but you have to remember the diabetes in the kidney is a consequence of things of uncontrolled blood sugar, obesity or overweight, high blood pressure, smoking, high protein diet, medications such as ibuprofen. So we have to also treat other risk factors to decrease and ameliorate the kidney dysfunction, because otherwise, if we just concentrate on the medication and we forget about the lifestyle change, you forget about other things, then we are not tackling all the aspects that affect the kidney. I wanted to thank you for your attention. We have a next talk on December 8th. We have the topic is going to be oral medication for diabetes. Older and newer agents. We had the pleasure to have Catherine Soller. She's a nurse practitioner with Sage Endocrinology in Albuquerque. And she has more than 10 years of experience talking about working with patients with kidney disease. And she's going to be, I think, great. And we really appreciate her to be on board. I think this is what I have for now. If you have any questions.
Excellent. Well, thank you, Dr. Barrantes. It's amazing. It always amazes me, what the medical technology and the advances that are being made and how that seems to be, changing almost daily. It seems to be going nonstop. But I really appreciate the last point you made there on the takeaways, in that these aren't solutions. These are treatments. They can help, but the core issue goes back to the as you mentioned, those lifestyle and the risk factors. So that's really where we need to make sure we attack this issue of kidney disease, particularly here in New Mexico, with the higher propensity of our people for contracting kidney disease. So with that, let me look and see if we have any questions. We've had a number of people attending, and several of them are expressing their gratitude. I would note that throughout this presentation, there were some polls that we tried to activate. So if you had the opportunity to answer those polls, that would be interesting to see your responses. So we would appreciate that. Also, just to keep in mind that this is a monthly event that we'll be doing. First Wednesday of each month, same time, 5 o'clock Mountain Standard Time now. And so please keep looking for us on our webpage. Go out there and like us, and share this with others that either with regards to diabetes or kidney disease, or the general health factors that Dr. Barrantes noted there too. This is good information for folks who are taking those actions to improve their health. So we appreciate that. So let's see here. If there's anybody who would like to ask some questions, go ahead in the chat section. You'll have to type those in, and Dr. Barrantes will be able to address those for you. So I'm looking right now. I would note too that these presentations will continue to be posted on our New Mexico Kidney Foundation Facebook page. So you'll be able to find them there under the event section. So if you need to come back to them, or if you would like to share this information with anybody else that you know, feel free to go to those sections, and you'll find our postings for both of those. In addition to other useful information that we are trying to post there on a regular basis. So go ahead and like us and follow us. We'd also would encourage you to go to our website. It's at www.nm, as in New Mexico, kidney.org. There's resources available there, as well as information on actions that you can take with regards to kidney disease, and to help us in New Mexico to reduce the occurrences of kidney disease through prevention and through treatment. So please visit our website as well. So we do have a question, Dr. Barrantes.
Sure.
So Patsy has asked, first off, she said it's very interesting, and several people have expressed gratitude. They say thank you for the presentation. She asked, is there a risk factor in taking the Jardiance with a PT that also have, with a patient that also has liver disease?
Well, that's a very important question. That's a very important question. And I think and the answer is it will depend. It will depend what type of liver disease we're talking about here. It will depend what other medications are involved. It will depend what is the degree of overweight and fatty liver disease. I think there are many factors to consider. I think Jardiance and medication that we are starting to know more about, and we are learning more about. I think as long as there are no contraindications in general for her to take it, and looking at the medication interaction, for the most part, it's a safe medication. But again, the data here is only a few years data. We have seen that these medications are effective, but the trials that have been published, ranges anywhere between 3 to 5 years. So sometimes you discover things later after several years of ill side effects. So at the moment, the medications are safe, and to my knowledge, to my recollection, I haven't encountered a liver contraindication from Jardiance, but it will have to kind of be looked at more carefully. What type of liver disease we're talking about here, because that many of the medications, get metabolized to the liver, but this medication they are metabolized in a different way. They go to a urine actually, and they act in the kidney. That's where they block. They block in the kidney the receptor, and then they make you pee glucose or sodium. So that would be my answer. So not to my knowledge, but we'll need to kind of look more carefully what other medication she's taking and what type of liver disease are we talking here.
Very good. It's always important to be mindful of whatever medication with regards to kidney disease, and making sure consulting with your doctor with regards to taking any medication, making sure we're taking it appropriately. So I appreciate that. Well, if there's any other questions, we'll be happy. We have a few more minutes here. Dr. Barrantes can answer those. And we do appreciate, too, Dr. Barrantes, the information in the presentation, the PowerPoints. Even someone like me who's not at all familiar with the medical side of all of this, it's both interesting and informative. So I do appreciate your ability to communicate that well to novices as well. Let me look here and see if we have any others. Well, if there are no further questions, we'll go ahead and thank you all for attending. And again, we'll look for us next month, December 8th, Wednesday at 5 p.m. Mountain Standard Time. And we will continue to have these kidney talks, is what we're calling them, just informing individuals, people throughout the state with regards to treatment for kidney disease, living with kidney disease, and also preventing kidney disease. So everyone have a good evening, and we will talk to you in a month. Take care.
Thank you very much. Thank you. Thank you. Bye.
Bye-bye.